Hi friends, it's Deanna Willison with Our Blooming Catholic Life. And you may be saying to yourself right now, why is she doing this video? I don't need this. And you may. You may be on the provider end. You may work in youth ministry. You may be a volunteer on the bereavement committee of your church. You may be on some Sacramental Prep. You never know when you're going to need this information. And you just need an exposure to it at this point. The document I'm going to share with you is a wealth of information. Is it exhaustive? No. Does it take the place of professional training or counseling? No, but it is a starting point. So I am not a medical professional. I have been trained somewhat in spiritual direction. I have social work training behind me. I have a master's in education. I'm not just Joe Schmo off the street, but I know enough to know that I don't know everything, and I'm not attempting to here. This is to give you an exposure to some of the words and terms that you may hear. And this document says that it is Suicide Safer Care, a toolkit for primary care providers working with geriatric patients. That is the document we're going to go over. It really isn't exclusive to geriatric, and they don't discuss some things that I wish they were that are specific to geriatric patients. So it's more generalized, but you may think it's only if you work with depressed people. But I'm telling you, I worked as a chaperone before, a volunteer chaperone in youth ministry, and whenever a small group was assigned to me, there were times when it was, this girl plays lacrosse, she's been hit in the head this week, she's a suicide risk. Keep an eye on her. Did I know what that meant to do? No. Or I was not even a small group leader at that moment. I was an adult in a group. We had a speaker come in to talk to the youth, and somebody left that room. And that somebody had suicidal ideation and was bawling in the hallway. What do I do with that? I did not get the training to know. And I found out there should be documents that are sent with these youth so that we do know what to do. And if they don't have the documents, we can sit and help them write it or refer them to somebody who can. Don't just send your suicidal teen off to youth ministry. But you're saying, but wait, how does this apply to geriatric patients? Other triggers for suicide besides depression are changes in medication. When I said head injuries for that girl who played lacrosse, how many times do we know that seniors fall and hit their head? That's a head injury. They are now susceptible. We need to be aware of that. Starting and stopping and tweaking medication that happens in your teenage years happens a lot with geriatric patients as well. We need to know that, as well as your bereavement committees. No matter what the age is, when you lose a spouse, a child, a dear friend, that could be someone's last friend that they have. We need to have the systems set up for support. What does that look like? Let's jump in here just a little bit into the document, but I'm saying you are probably going to want to see this. This document has links when we find it online, so many links to further trainings. If one of these topics speaks to you, jump out and try that training. This is an overview to get your feet wet. Again, if you're in any kind of church ministry, if you're just Joe Schmo on the street, this may happen just with a neighbor, a kid's friend, whatever. It's just nice to be exposed to some of the terms and words. The table of contents here is set up pretty nicely. I would always like the lines that go over, but the bolding is really helpful so that you know your sections. What are your sections here? Background. Why primary care? This document is addressed to primary care, so that's just their angle. They're trying to get primary care physicians to make suicide care a priority, but it really does apply to all of us. Common risk factors and warning signs, brief evidence-based interventions, and other considerations. That is resources and example training grids. So what is suicide safer care? It is a national priority, and much work has been done to review the existing evidence and identify gaps in how our nation's mental health and healthcare systems address this public health challenge. And I'm going to say it needs to apply to ministries. So many times I've seen counselors and small group leaders pulled out with one person to discuss suicide care. So don't think I'm not in healthcare. This isn't important. If you're in any kind of ministry, you need this training as well. So a national task force was part of the effort to update the National Suicide Prevention Strategy, review the research and best practices from the field, and concluded that suicide prevention could be improved in primary healthcare. I'm saying across the board. The task force found 3 common characteristics among successful suicide prevention programs in healthcare settings. They thought they need to believe that suicide could be prevented in the population they serve, in improvements in service access and quality, and through systems of continuous improvement. Constant training, right? They needed to create a culture that found suicide unacceptable and sets and monitors ambitious goals to prevent suicide. This is especially challenging in our culture right now. Euthanasia is getting legalized, and we know that is including terminal patients, geriatric patients. Our service members are getting pushed into that, depending on where you are in the world. We know that is happening, as well as it's happening now for children even. It's disgusting. So the more you make it acceptable, the more people do it, right? So we need to make it unacceptable, but in a way that has kindness to it, so that if somebody does die by suicide, the family isn't also all despondent and there's a chain of suicide. So it's a very delicate issue that needs to be handled delicately. I don't know how else to say it. We need to make it unacceptable, but also in a way that shows loving kindness, right? We also need to employ evidence-based clinical care practice, starting standardized risk stratification, evidence-based interventions, and patient engagement approaches. In other words, if a teen says to you, I have thought about suicide, you need to figure out, are they saying they're suicidal right now? Or they're saying it's happened in the past and it's something that might not need addressed, but maybe down the road. So we just need to be aware of it. So we need to have our levels. Where are we on this scale? Are we needing immediate interventions? Do I need to call an ambulance right now? Do we need a psych hold? Like, what's going on? I'll tell you now, this document says that's very rare. We want to do the lowest level care that we need to do, the least restrictive setting. We don't want to make it so that people are scared to come for help. Let's see what we can do in the moment. But at the same time, we can't be afraid to call for that crazy help if we need it. Crazy help. That highest level of care. You see how easy it is to slip into saying the words, my apologies. But I mean that over-the-top care is sometimes needed, but it's only needed when it's needed. So how do we figure that out? This guide focuses on 4 core components. We want to screen and identify patients of all ages at risk for suicide starting at school age. See, why is it a geriatric document when it's saying we need to start at school age? Assessing patients at risk. We need to restrict access to lethal means and safety planning. And that's where I think youth ministry can really come in, safety planning, and caring for patients at risk for suicide. The final section is going to be some additional information on administrative and legal issues providers and leaders may find helpful to support the integration of suicide safer care into practice. Many providers and clinical leaders erroneously assume if they discuss suicide with a patient that they themselves open up to liability. Utilizing a patient safety approach, primary care organizations can establish suicide safer care practices that deliver high quality care to patients of all ages and reduce risk to the organization. So there's going to be summarized information, a list of recommended trainings, leadership actions organizations can take to help providers reduce suicide in their patient population, in our youth ministry groups, in our churches, in our Sacramental Preps. Relevant tools, templates, and case studies. Awesome. The toolkit gives you a brief background of the impact of suicide and offers some great tools for you. Let's look. The rate of suicide deaths are increasing. Suicide is a leading cause of death in the United States. It's increasing in firearm methods and in all but 4 states in America. Non-firearm methods are also increasing. That's horrific data right there. Geriatric suicide. Did you know that there are, in 2020, among adults over 65 years old, 25 of our seniors committed suicide every day. 25 every day. That's insane. What are their unique factors? I won't say they're unique, but they're probably greater risk factors. These things happen more often in these age groups. So grief over lost loved ones, loss of self-sufficiency, chronic illness and pain, cognitive impairment, financial troubles, social isolation and loneliness. That transition to middle to old age brings rapid changes to an individual's social, environmental, and personal circumstances. Geriatric individuals are actually at the greatest risk of completed suicide. That means they've actually died during the suicide, not just an attempt. They are at the greatest risk for completed suicide. Why? They have greatest access to firearms. They're adults, right? Also, they have access to medications. So they are at increased risk of self-harm, repetition, suicide, previous history of self-harm, previous and current psychiatric treatment. They're often single, live alone. Instances of self-harm are also more lethal, right? Because they have access to the firearms and the drugs, and they're at poor health to start with. Rural adults are especially at high risk of suicide because they have less access to health care often and higher firearm ownership than an urban area. And suicide rates by firearms are still higher for white men aged 75 years or older, 3 times higher than their African American counterparts. Isn't that crazy? It is. Depression is highly associated with suicide risk. 69% of older men and 50% of older women who died by suicide did not have a known mental illness. But physical illness such as cancer and liver diseases are at higher risk. I'm not going to list all of these out. I don't want to be putting that in people's minds, but it is here in the document for you to read. And it lets you know that geriatric primary care providers are uniquely positioned to identify risk and intervene. And I'm going to say in areas without access to health care or times when the geriatric population or even our youth and young adults resist going to health care, they may still be going into church. That's where we have a unique way of preventing suicide. What are some common risk factors and warning signs? I've added some, but this is something that can be very helpful to print out on a chart and have available. If the person talks about feeling hopeless, trapped, having no reason to live, being a burden to others, experiencing unbearable pain, or talking about suicide, they could be talking about family needs or things that their family has said about them. If their family needs money and they have a lot of life insurances or trusts that will be activated upon their death, they may start feeling like this is the only way they can help their family. That is one level. If any of the following behaviors or conditions are present, increased use of alcohol or drugs, looking for ways to end their life, such as asking people, searching online, if they isolate from family and friends, visiting or calling people to say goodbye, aggression, displaying severe or overwhelming pain or distress, and that can be emotional pain or distress, withdrawing from activities, sleeping too much or too little, giving away prized possessions, writing a will suddenly at young people. This applies to any age. A will is completely a responsible thing to do, but it's the suddenness of doing it that can be an alert. I'm adding some of these in. Fatigue, family history of suicide or self-harm, local suicide epidemic, and that applies to self-harm as well, previous suicide or self-harm attempts, loss of a spouse, a partner, or best friend, UTIs. Do not rule that out. UTIs have a different effect on our older populations than they do on younger, as well as they are more susceptible to it as mobility is decreased, and possibly having to share bathrooms in a facility or something makes it more difficult to get to the bathroom. UTI risk is increased, and UTI has some mental effects on people that can be very scary, as well as medication changes. Changes in medication, they need to be closely monitored, as well as changes in condition. Maybe your medication's not working anymore. Irregular schedules as well. If you notice their irregular schedules, maybe they're suddenly taking a lot more pills at a meal. It could be like at a soup kitchen or something. You see them pulling them out. Are they waiting all day to take that one meal that they have at the soup kitchen, and they're trying to take big boatload of medication all at one time, or you see I've forgotten my morning meds, so I'm going to take them with my afternoon meds. Those are things that should make you worry, because maybe there's some they're not taking on their regular schedule, they're not taking appropriately with food. Those all have effects. So if you notice changes in taking their medication, perhaps you're a family member that stops by and helps set up their medicine for a week. Check those containers. Are they all empty? You may want to switch to something that is a dispenser that gives them at the appropriate time of day in a little packet. These are just things to kind of look for, that these are red flags. If the patient is describing or evidences feelings of depression, rage, humiliation, impulsivity, sudden sense of peacefulness, loss of interest, irritability, agitated anxiety, and despair. The sudden sense of peacefulness may throw you off, but that could be that they've made a plan to die and they are now comfortable with it. And they're thinking, I can handle this pain. It's just for one more day. Then I'm going to be out of here. And that is the scary kind of peacefulness. They then talk about routine screening and assessments, so that they are going to review the person's medical history and look for risks. They are going to use a brief survey when a person comes in for their yearly visit. They are going to go over those screening questionnaires before the patient leaves for treatment. So those are for them. It does also warn you, so this is where Sacrament Prep may come in. In patients who are there for baptism prep, you may notice some depressions going on with the pregnant woman or postpartum depression, and that could just be something for you to be aware of. Screen patients, yes, experiencing transitions in care. So if somebody is suddenly in a nursing home or something, they're transitioning in different levels of care. If you're someone who is visiting that nursing home, a Eucharistic minister, a priest who's going in, just look for those warning signs. You can let their appropriate care person know, but if you see these red flags, to let them know. Yeah, okay, we already talked about the UTIs and medication irregularity. I added those in. Those are not in this document, and I don't know how they're not in the document for geriatrics. That's crazy to me. I found those issues myself. They do talk about screening all patients. They give you a basic questionnaire, and you don't have to give them a questionnaire. You can work some of these things into conversation. Consider making accommodations for geriatric patients who may have difficulty to hearing, vision, or memory impairments. You can't just give somebody a questionnaire or work that out. They may need help reading it. If they have lost some of their cognition, you may have to try and assess these or come at these from different angles. If they have memory loss or something, it says if they're struggling with memory loss, and that could also, again, be a teenager who's had a head injury, you may want to use local events or holidays to help them establish what time of year it is so that they have some frame of reference. And then they give you, again, a number of screening and assessments. If you're online, you're going to see this. It gives you an example. Now, this is given as a well-researched. It tells you who all has the money and all, how they got this. The patient questionnaire that's called 9PHQ9, there's no coded questions. You could simply just answer 0 and look like you're at no risk. That's easy for a person to do. There's no trick questions in here to catch if you're just circling the same number. But how this scale is laid out, again, why I would discuss this and then maybe mark it for the person, because otherwise you may just get some false negatives, false positives in here. Little interest or pleasure in doing things, and you would say, not at all. Several days, more than half the days, nearly every day. Feeling down, depressed, or hopeless. Trouble falling or staying asleep, or sleeping too much. Feeling tired or having little energy. Poor appetite or overeating. The last question here is not one that you ask every time, but you would use appropriately. Thoughts that you would be better off dead or hurting yourself in some way, or that those around you would be better off if you're dead. So that's one that you can kind of get a gist for. So again, you may not want to ask them. These may be observations or things that you do in conversation, except for really that last one. Reserve it in case they have higher numbers. This one was a lot easier, I thought. Now this is the answer sheet, but this is called the Geriatric Depression Scale. short form, the GDSS. And this is a series of questions, and it tells you in bold a good answer, the answer you want to see, and the non-bolded one is the one that puts them at higher suicide risk. So choose the best answer for how you have felt over the last week. Are you basically satisfied with your life? Have you dropped many of your activities or interests? Do you feel that life is empty? Do you often get bored? Are you in good spirits most of the time? Again, you can kind of work some of these into conversation and then mark them later to use if the person is at risk. It says help from your EHR, and that's a computer system that they have, electronic health records. So that could be built-in templates and things that are going to help you if you have that. Like as a spiritual director, I don't really keep written records. I have some little tiny notes, so I don't have this. But if I had somebody with some sort of suicide risk, I would probably mark something. So it gives you some codes that you can use in your electronic health record for these. There's more under page 12, suicide risk assessment. There are some provider communication tips. You want to orient your patients before moving into it. You want to ask matter-of-fact questions, orient ahead of time that you are going to follow up, and don't worry, there's going to be some examples. Orient that you are going to follow up on these questions, but you have to ask the most important questions first. So sample introduction. At our parish, we feel that it's really important that we ask you about suicide. So parish, hospital, whatever. As a provider, I know that suicidal thoughts are not unusual. At the same time, they are a good measure to see how much you're suffering. So we're going to try and look at these questions and see how you feel. You can review the responses with each one, working your way to question 9. Like, I see you're having trouble sleeping, and you report that for most days. I also see you're having trouble concentrating on some days. These could be related. I see that you're having thoughts about being better off some days. Thank you for sharing that you're thinking about suicide. Your life matters to me, and I would like to ask you a few more questions about suicide. So what are some other things? Again, there's things that you can say. Thank you for sharing your suicidal thoughts. I won't be asking for the details now, but they are important. Suicidal thoughts are not unusual, but they're a good indication for how good or bad things are going, right? It is hard to think clearly when our brains are overwhelmed with emotions, and many people don't understand this. Some people in despair imagine suicide because their brain wants a way out of intense pain. It would really help me out if you removed the gun from your home, at least temporarily. What you do with your suicidal thoughts makes the difference. You can acknowledge them, but direct your attention away from them by focusing your attention on something else. There's then another severity skill. So this one has 2 questions that you would ask first. Have you wished you were dead or wish you could go to sleep and not wake up? Yes or no. Have you had any actual thoughts of killing yourself? Yes or no. If they'd answered yes, then you would say things like, have you been thinking about how you might do it? Have you had thoughts with some intention on acting on them? Have you worked out details on it and made a plan? Do you intend to carry out that plan? And then, have you ever done anything, started to do anything, or prepared to do anything to end your life? This is getting a long time history, lifetime, or the past 3 months. So some of these, it tells you may just need to do a lethal means restriction and safety. You may need a behavioral health consult and consider some patient safety precautions. You may need to make a patient safety plans. Again, it tells you the boxes are color-coded, that you can answer them. And that's for you see the questionnaire, you ask it, and you mark it for them. You're going to need, it's well scripted for use by non-mental health professionals, and there's online training available. That's the one we just looked at, this CSSRS. Includes triage guidelines, can double both as a screening tool and a risk assessment tool. There are some other trainings, the self-talk curriculum, this is for non-clinical members, and the mental health first aid kits. Every patient who is identified at risk for suicide must be closely followed up with a suicide care management plan. That's not scary. Like, I have a management plan for if I get stung by bees, I'm allergic. It's not just use EpiPens or take this medicine. It's a written out list of things that I may need to do, things you may need to look for, what the escalations look like, and that's for an allergic reaction. This is similar. This is a condition, a risk that this person is at, and it's what we do at different levels of risk should it happen. This is a great plan to have, honestly, with anyone who's especially living alone, and you're going to see why. It does tell you it's not just one provider, it's a whole care team. We're working as a team. There's some charts here. It says we really need to create a safety plan with the patient. That's not, it says working with geriatric populations. We need to do it with everyone. We need to create a safety plan with them. It's not going to work if they don't help make it. Reduce their access to lethal means. We need to use clear and caring patient-provider communications like we just talked about in the last one. Thank you for sharing that with me. And that sounds really trite. You're going to use it in your own language. I know, that's really hard to talk about. And I feel really honored that you would talk to me about that I'm here for you. One of the reasons we're making this safety plan is things like people in your head. You may say, if I get bad, I'm going to call so-and-so. So-and-so may have on their phone a sleep function that only calls from specific people come through. So you may be calling them in the middle of the night and their phone's not even ringing. You need to tell that person, hey, you're my safety person. I need you to have your phone on so that I can call you in the middle of the night. It's as simple as things like that. I think teenagers should all have that as well. I really think we all should have a person, at least, that has that capability. But we'll get to that in a minute. I really think it's just like, it says, it's just like any other problem. We're going to want a care plan. Even if you had a broken arm or something and you were living alone, you'd want to have a care plan. The safety plan should be brief and the patient's own words easy to read, involve family members as full partners in the collaborative process, especially to establish their role in responding to patient crises. You need to let the person know that you're including them in this. A plan to restrict access to lethal means, which is also balanced with respect to legal and ethical requirements under federal and state laws. Be updated whenever warranted. Be in the patient's possession when he or she is released from care. So a lot of the tips are put 988 into your phone. So I need to do it here. But before I let somebody leave my presence that I'm worried about, I want to see that it's in your phone, that you know it's there. I want to know it's there. It's going to make me feel a little better. But when you're in crisis mode, you're not going to be able to remember that number perhaps. So let's put it in your phone in a way and label it something that you're going to remember what that is. I don't want you to leave without doing that. And I think that's fair for a lot of people. Now, nowmattersnow.org safety plan. It is an emotional fire safety plan. I think this is amazing. I loved this document. There were a couple things I thought needed updated, but not a lot. So what this looks like is it tells you what to do for emotional fire prevention when you're in the fire and when you are on fire. So on fire is the top one. This is probably color-coded online. I printed it black and white. Direct advice for overwhelming urges to kill self or use opioids. Shut it down, which is sleep, no overdosing. If you can't sleep, take a cold shower or put your face in ice water for 30 seconds and repeat. This is a reset button, and it will slow down your thinking and allow you to start processing things. No important decisions. Don't make any important decisions when you feel like you're on fire, especially deciding to die. Don't panic. Ignore the thoughts that you don't care if you die. Stop taking drugs and alcohol. I will say here, though, do not stop taking your regular medication. It's regularly scheduled. If you're not sure, call your medical professional first before taking your medicine. That's an appropriate one, but when you're on fire, I think that's going to be difficult for you to do. You're going to need to make eye contact. This one sounds crazy too, but making eye contact. Difficult but powerful pain reliever. Look into somebody's eyes and say, can you help me get out of my own head? Try a video chat if you need to. Keep trying until you find someone. So if you live alone, you're like, I can't do this. Do a video chat. Most phones have that. Again, if this is someone that you're making a plan with and you don't know if they know how to use video chat, make sure they learn before you let them leave. If you are in a fire, and this is a list This one is a check mark list. So the other ones were for everyone across the board. In a fire is a check mark list, and you're going to check the ones that you think will work for you. And you're going to practice these when you're not in a crisis situation so they become a little automatic. Things I know how to do for suicidal thoughts and urges to use drugs. You can visit nowmattersnow.org, which has guided strategies. You can try the ice water and paced breathing. Exhale longer. You can call or text line or an A team member, and that A team member is going to be your core team of friends. You're going to decide on who that is, and that's listed below. Don't worry, we'll get to that. Say, it makes sense. I'm stressed or in pain. So you're acknowledging your feelings. It makes sense. I'm not being crazy here. This makes sense. I'm very stressed. I'm in pain. That's why I feel this way. Okay. And then also say to yourself, I want to feel better, not suicide or use opioids. Whichever one of these works, remember, we're going to mark it. There could be another distraction. There are blank spots where you can pick something and write it in here. This list is also really tiny print, so you're going to need to make sure a person can read this, especially if the person normally wears glasses, and when they're upset, they may not be wearing glasses. Make sure this is done in a way that they can read it. It could be a file on their phone. They can take a picture of this when they're done, and it's on their phone as a top thing. Do the opposite action. Act exactly opposite to an urge. Mindfulness, by which they mean choose what to pay attention to. I'm freaking out. I feel like I'm on fire. I'm going to go outside and I'm going to take my shoes off and walk in the grass for a minute and just feel that sensation of the grass. And I'm going to focus on that sensation of the grass. Maybe you have a sensory thing. Maybe you have like a feather and you just stroke that feather until it helps calm you. You're just going to focus on the feeling of that feather. Maybe you have a fidget. Fidget wristlets or blankets can be very helpful. They're normally handmade, crocheted. It can be something you wear and it has little curly spirals, all different textures on it. And so you're going to focus on those textures and it's going to take your mind off. That really helps sometimes with people who self-harm as well. There's a variety of textures. It can be a blanket. You can get a variety of fidgets that will help you with that. And you would write that in, that's what you're going to do. Mindfulness of the current emotion. Feel your emotions in your body. So you're in a fire, you're completely overwhelmed, you're feeling like you're going to kill yourself, and say, what is this emotion that's driving this? I'm lonely. I'm really lonely. And that sucks. But knowing that you're lonely is going to let you identify what to do next. If you're feeling really lonely, you're probably going to want to do a video chat with someone, right? Give somebody that video chat. Okay, if I'm really angry, maybe I want to go get a ball and bounce a ball, right? I've learned that one for frustration and anger, throwing like a ball against a wall or the floor can really help. If you don't have a ball, grab a pillow. Usually throwing something heavy works best, but you are going to figure out what those things are and you can write them in. You can have this included for different emotions, what you're going to do. I think I'm pulling that back from my memory from a program called How Does My Engine Run? But you can find that there. I can manage this pain for a moment. That could be something you say. I don't feel like in this moment I can live with this pain forever, but can I live with this pain in this moment? I can do this. Notice thoughts, but don't get in bed with them. So, whoa, like where did that thought come from? Don't sit there and concentrate on that suicidal thought. Move on to something else. And that may also, for some people, it may be pray a certain prayer. Get up, go to the adoration chapel. It may be pick up your rosary beads, and all you may be able to do is hold on to them. You may only be able to say this one prayer that comes to mind, no matter how stressed or whatever you are. You can write these things in. That's fine. This is not geared for a religious setting, so they aren't here, but there's blank spots. You can write these in. Okay, so in fire prevention, things that you can do preventatively. Put crisis resources in your phone. And again, it does say take a photo of this safety plan with your phone and practice calling and texting these people. There's a suicide prevention lifeline, which I believe is 988. And there are special things that you can do in there to get Spanish or to get a special line for veterans. There may be some others. There's other crisis text line. nowmattersnow.org has a helpline. My 3 Safety Plan app. There's a number of apps that are listed here. You could also dial 911 and ask for the mobile crisis unit. There are ways of keeping yourself safe, and you may need to talk with other people about that, other people in your house or where you live, whatever, or just family members. So it could be guns locked up without the key or combo, guns stored separately from ammunition, guns stored outside the home. Your A team, and again, we'll discuss who the A team is in a minute, supports these safety steps. Confirm steps with another person. You need to address suffocation and overdose thoughts. Preferred suicide methods are reviewed and addressed. So just like the guns are going to have specific safety methods, if you're at risk for overdose, you may need to get your medications out of the house, maybe have somebody else administer them to you, things like that. So you're going to need to come up with plans for your specific way you're thinking. It could be, yes, remove opioids from home. No one with or using opioids allowed in your home. Remove or store prescription medication safely. So it's going to be specific to what your temptations are. Then you're going to write down the reason why I want to live or not use drugs. Beautiful. You write that yourself. What is your reason? What is a visible reminder of that? Again, it can be something you put in your phone or wherever your temptation is. If your temptation is guns, you're going to put that visible reminder there. If it's medicine, you're going to put that there. If it's something to do with the car, you're going to put it there. You may need to put something in your wallets. Whatever is going to be most accessible to you in that crisis moment, that's where you want to put it. What is the number one thing leading to your suicidal thoughts or urges to use? Figure out what that is and then make a plan to get you out of that, right? Create an A team. Who are the A team? I said we talk about, here we are, people that I can talk to about suicide, drug or alcohol, or mental health structures. You're going to choose them. They can be healthcare providers, peer support, friends, or family members, or others. If you're a teenager, you need to include at least one adult in your list. I'm telling you that now. Your friends may be just as overwhelmed. They're not going to have this training. They aren't going to know what to do. You may feel that they're safe, but they may not know how to escalate the levels. They may just be at the basic level. Please include adults. And these A team members need to be brought in and given the training. So even your teens need training, but that doesn't mean that we're going to kick the adults off the team. We need adults on the team. If you're a senior, you don't just want seniors. We're going to have to update this list as well as people move away or they may pass away. If you're geriatric, your A team may die. That's realistic. That is where the loneliness comes in. So we're going to make sure we have a variety of people on our A team. It's not just a person, it's a team. And we are going to choose them. We are going to message them or call them individually or as a group to let them know. Doing it as a group is wonderful because then they know who each other are. That is going to be helpful as well. Discuss in advance what would be helpful in a crisis. What do you want them to say? I believe in you. You can do this. There are things we all know that people can say that just gets on our nerves and things that are genuinely encouraging. So if you know what those are, tell those people now. Do you want them to support the plan? Do you want them just to listen? Do you want to take hospitalization off the table? Do you want to say, if I'm in a crisis, I only want women officers to approach me? That can be that's a safe thing to say. So try and figure these things out. And you need to figure out what you can do to ask for help effectively. You have to know that you need to be able to communicate before a crisis. So say to yourself, what can I do? When I am feeling this, I am going to call this person. When I am feeling this, I am going to call this line or whatever it is. Make up your team. Decide how you're going to ask for help effectively. Practice the words. The words can be hard to say. Practice saying, I'm feeling suicidal. I need help. It may just be as simple as that. Then there are things that you need to watch out for with things you'd be willing to try. Now, how the things to be willing to try or the things to watch out for may be different for you, so you're going to need to script those out. So it's not sleeping, something that's a warning sign for you. If you're not sleeping, do we need to try regular sleeping for a week? Try and get 8 hours of sleep for a week. And then we may need some strategies to help us get there. If you're feeling really anxious or irritable, validate yourself. Say, my emotions make sense. Oh, on the sleeping, you could give yourself a reward for every night you get X amount of hours sleep. Do that. Increased alcohol, drug use, or relapse. Talk to someone in recovery. If a warning sign for you is being frustrated in painful situations, make plans to get out of these situations. If you stop taking medication without support, then you need to go to scheduled appointments or schedule an appointment. If you know that avoiding calls or messages is a sign for you that you are going in a dark place, you need to message an A team member a caring message. And then suicidal thoughts or images, what's something that you know helps to get you out. So they don't have to be 100% things you know are going to work, but things that you would be willing to try. It now then gives us the nowmattersnow.org emotional fire safety plan. It gave us that really detailed one on the other page, and this is more of a blank one, so you can fill in those things that you worked for you. The patient safety plan, and this is another great list. These are all in this packet. That's why I'm saying this packet is full of all kinds of training links and resources that you're going to get exposed to here. Basic sections. The one online training that really jumped out at me that I'm going to take is CALM, Counseling Access to Lethal Means. I know I want to take that. I'm going to look at some of these other ones. One says about reducing the access. What does that mean with still getting medications and monitoring? Like, what does that look like? Medication and drug overdoses are the most common means of suicide attempts. Because medications may be needed by the patient or other family members, large quantities should be secured in a locked box, such as a steel toolbox with a padlock. Parents should dispense medication prescribed to the patient. Over-the-counter medications should be secured as well and replaced with small quantities if needed in the home. Special attention should be paid to high-risk medications such as antidepressants, sedatives, and opiates. Pharmacists can also dispense smaller quantities to high-risk medications. I forgot about this in my earlier ones. I've also recently learned that diabetics, when their blood sugar is going all over the place, they can do some really wacky things too that we need to look for. Things that are completely out of character, including suicidal thoughts. It can mess with your head. So we need to look for that with diabetics as well. Let's see. There are some short videos you can show. Caring contacts. How do we have caring contacts? It says postcards. I wouldn't do postcards necessarily because people can read those. But letters, patient portal emails, text messages, phone calls, visiting a person. There's something here called caring messages from Now Matters Now, but I can't read it. That's not legible to me, so I'm going to have to look that up on the website. Again, Now Matters Now seems to have a lot of great resources. The alternative levels of care, we're going to have to decide what kind of referrals may be appropriate. It does say emerging evidence suggests hospitalization should be avoided if at all possible. There are reminders about HIPAA. It says when suicidal ideation is present, contact family members or friends when possible. According to the Joint Commission, for patients who screen positive for suicidal ideation and deny or minimize suicide risk or decline treatment, obtain corroborating information by requesting the patient's permission to contact friends, family, or outpatient treatment providers. If the patient declines consent, HIPAA permits a clinician to make these contacts without the patient's permission when the clinician believes the patient may be a danger to self or others. And you could have somebody sign a paper like that if they have a head injury or something, they're coming to you, have that written out that you are allowed to contact the appropriate people. That needs to be in their plan. If that's in their plan, you can do that. Okay. Care transitions. If people are going to inpatient care, coming to outpatient, like whatever, changing your level of care, those transition times are pretty big. And so we need to look for that. If people don't show up for things, that can be a warning sign as well. That's most of what is going to apply to most of us, but they do have a number of training kits. There's also the Zero Suicide Toolkit, and I'll probably be looking at that one as well, and I'll let you know after I look at it. There's then what kind of training is appropriate for different kinds of job titles. I thought that was really helpful as well, and I think that we could extend some of this into the realm of church life and ministry. That was a long one. I hope that you are blessed with this. We're just going to say a little prayer right now. In nomine Patris et Filii et Spiritus Sancti. Amen. Heavenly Father, we just thank you for all of these resources, for all the love that you show your children, and that we may be bearers of your love to others. Help us to help them know you, know your love, know their worth. I just ask for all the graces that we need as we care for others. Amen. Pantries, Affiliate Spiritus Sancti. Amen.